right, I see folks are coming in at a good speed, so I'm going to start off doing some good old housekeeping. But first off, hello everyone. Welcome and thank you for joining us for this seminar, Strengthening the Design of Site-Tailored Effective Implementation Strategy Bundles, Applying the Core Function and Form Framework to Implementation Strategy Typologies, presented by Dr. Brian Mittman. This seminar is part of the 2024 Institute for Implementation Science seminar series, which features lectures with leading implementation science experts. Registration for upcoming seminars and recordings from our past seminars can all be found on our website. We do have a few quick announcements before we get started. This seminar is being recorded, and the recording will be posted on our website after the event. All microphones are going to be muted, so if you do have any questions or comments during the seminar, please feel free to enter them into the Q&A box, as there will be time for questions after the presentation. After today's seminar, we will send out a survey for attendees to receive chess and MChess continuing education credits. But for now, I'm going to turn it over to our Institute for Implementation Science co-director, Dr. Bijal Bala, to introduce today's speaker. Thank you.
Thank you, Jeanette. Good morning, everyone, and thank you for being here. I'm really thrilled to introduce Dr. Mittman, who is a research scientist in the Department of Research and Evaluation at Kaiser Permanente, with affiliations at University of Southern California and UCLA, where he co-leads the UCLA Clinical and Translational Science Institute's Dissemination, Implementation, and Improvement Science Initiative. He is a leader in the field of implementation science, has been part of the launch of the flagship journal of the field, which is Implementation Science, co-founded the Institute of Medicine Forum on the Science of Quality Improvement and Implementation, chairing the NIH Implementation Science Grant Review Committees, and directing the VA's Query Initiative. These are all groundbreaking initiatives that have really advanced the field of implementation science. Dr. Mittman's research includes empirical studies to innovate healthcare delivery and implementation strategies, as well as advancing the science of implementation science through conceptual and methodological work. He currently has important advisory roles, including membership on the NHLBI Board of External Experts, on the AAMC Advisory Panel on Research, the PCORI Methodology Committee, and other U.S. and international leadership and advisory roles. We're really excited to hear from you, Dr. Mittman, and really share all of the wisdom and experience that you have accumulated in the field of implementation science. And with that, I'll hand it over to you.
Great, thank you. So first of all, my thanks for the kind introduction. I'll hope that what I'm sharing is going to be wisdom, but I'll certainly share a lot of ideas. Also want to thank you, obviously, for the invitation, the opportunity to present, and for the seminar series in general, which I think plays an important role in continuing to strengthen and support our field. So let me go ahead and dive in with right, I hit one button, nothing happens, so let me try another one. There we go. So basically two key points that I'd like to make, two parts of the presentation. And I will disclose up front that I will spend the vast majority of my time on part one, and that is laying out the background and motivation, talking about the kinds of challenges that we face as implementation researchers, talking about the unique needs and features of the phenomena that we study, and the corresponding unique needs and requirements for our research approaches. And then talk a bit about how some of our prevailing approaches don't quite fully address those needs and challenges. I will describe very briefly a proposed solution, but I suppose I should feel a little bit bad about a potential bait and switch because the title probably implies that I will devote more time to the solution than I actually plan to, in part because the solution is relatively straightforward as far as what we need to do. And I think the more interesting issues, again, are the background and motivation. So just as a preview and in summary of what I plan to say, I'll talk a bit about the nature of the phenomena that we study, implementation phenomena, and the fact that the barriers that we need to address and overcome are numerous. They tend to occur at multiple levels. They're highly heterogeneous, both across time as well as across place. The dilemma is that all stakeholders, and that includes we as researchers as well as decision makers, whose decisions we hope to support, as human beings prefer simple, fixed solutions. We are always looking for the answer with a capital A that is highly robust, highly effective across multiple settings and time, and that is relatively stable. Unfortunately, that doesn't work for us. It's rarely, if ever, an appropriate solution in the implementation domain. So what do we need by way of a better solution? We need to allow and embrace and even encourage adaptation and tailoring, as opposed to what we all learned in our research courses back in the beginning, especially those who were in medical schools and learned at the side of clinical researchers. We often like to suppress or ignore adaptation and tailoring and heterogeneity. We need to, again, embrace and study it and ultimately try to guide it. We should do so by applying the core function form framework that Penelope Hall introduced many years ago, and I'll talk a bit about that and talk about how it applies to the implementation science field. In the way that it applies is the task again in the plan that's laid out in the title of my presentation, and that is to take the existing prevailing implementation strategy typologies, Eric and others, and reconfigure them, sort them into a core function form framework or scheme, and develop theory-based menus of related strategies, and use that as our tool for designing and deploying, refining, and evaluating implementation bundles. So let me elaborate a bit on the issue of the challenges and the unique features of the implementation phenomena that we try to study. We know very well that the clinical phenomena, the practices that we aim to change, are highly stable. They're very slow to change. There's a fair amount of published literature, as you know, talking about clinical inertia and the conservatism of the medical profession. There are, of course, always exceptions and new practices that have diffused very rapidly, in some cases ahead of the evidence rather than in response to the evidence. But for the most part, it's useful to view the clinical practices that we try to change as this large boulder. And not only is it heavy and difficult to push up the steep hill, but we can sort of envision all of the various barriers that we need to overcome as a set of ropes and bars and chains that are holding that boulder in place. So an enormous challenge. We also know, though, that the pattern of ropes and bars and chains, the pattern of barriers, tend to vary across time, even within a site. They tend to vary considerably across sites and considerably as well across different clinical problems or practice change challenges. And again, as I indicated, the problems and therefore the solutions need to be multifaceted, multi-level. And we've learned very early, although we still seem to be learning this lesson, that relatively simple change efforts, deploying one or two implementation strategies, is not likely to move that boulder very much. The so-called onion model, the large body of literature that's captured here, is yet another way of illustrating the challenge, the fact that the behaviors that we aim to change, and in the case of implementation science, of course, it is professional practices of health professionals as well as institutional practices. They are influenced by a large set of factors. And many of these factors for any given practice change problem do represent key strong barriers. And so our implementation strategies or bundles need to address and overcome a large number of barriers at multiple levels. If we go back and look over the last 4 decades or so, especially back in the very beginning in the 70s, 1980s, when we saw a lot of research in the area of changing physician behavior, most of the early efforts deployed educational methods, reminders, financial incentives. In the way that I would describe those efforts is too little, too late. They often will address 1 or 2 barriers, often at 1 or 2 levels, and we don't see again any movement in that boulder. If we eliminate or loosen 1 or 2 of the ropes and bars and leave the others in place, that boulder ain't moving. And there were many studies, especially back in the 70s and into the early 80s, where the main finding was the intervention group physicians did display changes in their knowledge, but no change in clinical practices. So again, the clinical practices remained in place because of the various barriers that were not addressed and were not overcome. There are various checklists and lists of domains and factors that we need to worry about when we try to achieve change in professional practices. This is one such checklist, and basically, again, points out the numerous barriers that exist to prevent us from achieving the kind of practice change that we'd like to achieve. Now, one key point related to this checklist and others is that every implementation bundle for every implementation problem does not necessarily need to include individual implementation strategies to address each of these conditions. Oftentimes, we do see supportive regulatory or fiscal factors. We do see consumer acceptance. So the goal of this kind of checklist is not necessarily to develop a matching list of intervention activities or implementation strategies, but instead to assess current conditions, to identify the key barriers, and to use that list of barriers to develop the list of implementation strategies that we need to include in the bundle. So summarizing, again, we know that implementation barriers are numerous. They occur at multiple levels. They're highly heterogeneous across place, and they're also heterogeneous across time. They're dynamic. And the implementation solutions or bundles must correspond and address those various features of the barriers. We typically need multi-component bundles of implementation strategies. We typically need to have multiple stakeholders at the table and to design and deploy multi-level interventions. It's not enough for us to work only within the health system if many of the barriers are out in the community, because physicians are relying on established professional practices and norms that are inconsistent with the kinds of practices that the health system would like to employ. We know, again, because of the heterogeneity, that we need to deploy bundles of solutions that are highly tailorable to place and that also remain easily tailored over time. And because, again, of the local nature of the barriers and the heterogeneity and the differences, they need to be locally designed and locally delivered. So I think it's safe to say that we've all seen or and very familiar with all of these ideas. I don't know that there's anything that I've said thus far that is new and different or very profound. What I think is still problematic is the fact that the full degree and list of implications of these challenges is still evolving. We're still continuing to try to understand what to do about all of the challenges. And there are a number of key principles and assertions that I would offer that are among the list of implications. So we need to recognize that individual implementation strategies are rarely, if not never, completely effective or ineffective. We like to study vaccines, for example, and determine whether a vaccine is effective or not, whether the balance of benefits exceeds the harms. Because of the heterogeneity, I don't think we will ever see and should not be trying to develop a formula or approved list of implementation strategies, nor should we be trying to emulate our colleagues in the Cochrane collaboration and elsewhere that tried to estimate the pooled effect size, average effect size of an implementation strategy. The answer to the question, is this implementation strategy effective or this bundle, is always sometimes or it depends. So avoiding the kind of thinking that we've all been trained to embrace in the evidence-based medicine movement is one key implication of the nature of implementation phenomena. So not thinking about evidence in the traditional sense with a capital E and evidence-based practice are key implications. If we continue to think through and sort of walk down this path, I think it's clear that a manualized intervention, as we often conceptualize it, is also not appropriate. An intervention or a manual that lays out a set of specific steps and protocols, scripts for health leaders and clinicians to use and other fixed steps again, is more harmful than helpful because it basically encourages us to think about evidence in the traditional sense, that this intervention is effective, and it's not. It may have been in the setting in which that manual was developed, but that has relatively little implications for likely effectiveness in other settings. And I'll come back to many of these principles and statements over the next several slides. I also think that it's harmful to think about the concept of core components as we typically think of them. Again, a list of specific implementation strategies or intervention activities as part of a bundle may have been core and critically important in one setting, but when we go to another setting, that's not likely to be the case. So I would argue that every component that is core can be replaced with a different component. Now, it depends on how we understand and use the word core component. And my sense is that for the most part, it's used to describe forms rather than core functions. And I know many of you are familiar with that concept. I'll come back to it in a few slides. Another key implication, though, of walking down this path is the idea that the fundamental goals and purpose of research for us tend to be different from those in conventional clinical research. Again, we should not be aiming to estimate the effectiveness of a given implementation strategy, because, again, the answer is it's effective in some settings and circumstances and not others. And that's another concept in principle that I'll come back to later on. But one of the key points, though, is that many of our challenges in the increasing recognition of our incomplete work in guiding policy and practice, I believe, are directly tied to some of these issues. And that increasing discussion is illustrated by these two articles, and there are many others as well. The version that I've always used to convey these ideas is the saying, researchers who live in glass houses shouldn't throw stones, and talk that I've been giving for a number of years, basically arguing that our field, which is based on the recognition that clinical researchers who publish their findings and walk away and assume essentially that if you build it, they will come, are not completing their work. So our criticism of the clinical research field in its failure to recognize and address implementation barriers and to ensure that the evidence in the innovations that are published are actually adopted, I think applies to us as well. And that's sort of my take on what these articles are saying, that we need to take a good hard look at what we're doing in the field and ensure that the very rich and very useful work that we're conducting in methods development, in theory development and testing, in empirical research is complemented by careful attention and more robust and more intensive and more thoughtful attention to how our output is and can be used by practitioners, by health system leaders, by clinicians, by policymakers. And again, another principle and theme that I'll come back to a couple of times. So let's think about this. What is it that health system leaders and policy leaders need from us? When we think about vaccines and drugs, what the FDA needs from us, meaning the research community, is a simple yes/no answer to the question. Is this vaccine effective? Should it be approved? Should it be included in the formulary? And even clinicians, when they're faced with patients, think about this question. Should I use this drug or this vaccine? So for the most part, clinical researchers aim to produce a simple yes/no answer to the question, is it effective? We do so, of course, through the standard kinds of RCTs that we've all learned to conduct and appreciate the opportunity to conduct because they're relatively simple and clean and straightforward. We randomize, we measure outcomes. Oftentimes we have the ability to perform subgroup analyses and examine the heterogeneity that does exist in clinical research. It's not only a feature of implementation research. But by and large, these are, as I said, in quotes, relatively simple studies. And our focus is on outcomes or impact. So it is the case, as I said, that many drugs, many vaccines do have a simple yes/no answer. Precision medicine, of course, is moving us in the direction of heterogeneity and trying to understand when, why, where, and for whom interventions are effective. But the problem is for most complex health interventions, and I'll discuss and define that in a couple of slides, but it includes health promotion programs, implementation bundles, healthcare delivery interventions. There are relatively rare occasions where we can say, yes, this intervention is effective in a robust manner, meaning across time and place. But for most complex health interventions, implementation bundles, implementation strategies, as I've indicated, the answer to the question, is it effective, is sometimes or it depends. So there is no simple yes, no answer. So what are complex health interventions? There isn't a clear consensus definition, but for the most part, researchers tend to understand them to be interventions for which there are multiple components that interact. Complex health interventions often, through their multiple components, target multiple levels in multiple target entities, oftentimes patients and physicians, health system policies, regulatory policies. The interventions are highly adaptable. They can be tailored very easily. And the effects of those interventions occur through causal pathways. They don't have simple direct effects, but complicated effects. Now, the problem for us in the idea that complex health interventions are rarely, if ever, effective in a robust manner, I'd like to illustrate through two contrasting histograms. So these are the results of a hypothetical guideline implementation study where we are measuring changes in rates of adherence across a set of hospitals or medical groups. Blue are intervention sites, yellow or light green are the control sites. I don't know that any of us has ever conducted an implementation study that produces this pattern of results, where everyone in the intervention group did significantly better than everyone in the control group. This is what we tend to see much more often. A very high level of variance, considerable heterogeneity, and almost complete overlap between the intervention group and the control group. There may be a small difference in terms of the average effect size, the pooled effect size, overall effect size, but for the most part, you are almost as likely to show harm in the intervention group as you are in the control group. Now, that's a dilemma for implementation researchers and other researchers who study complex health interventions because the costs of our interventions are very high. It's one thing to say, let's go ahead and give 1,000 patients a vaccine. We know that only 40% of them will benefit, but the vaccine has no harms. We have no way of predicting who will benefit. And the vaccine is very low cost. So our only option is to either not give the vaccine to anyone or to give it to everyone, knowing that only a subset will benefit. It shouldn't work that way in the work that we do. We would not want to encourage health system leaders to adopt a program that did show a very small average effect benefit, but with considerable harm, because the costs to those who are harmed is very high. So again, it's a difference in the nature of the phenomena that we study and the kinds of interventions that we evaluate, and we need to think about the implications. So, I think it's clear why we see such heterogeneity and variability across effectiveness of these interventions. The targets and settings tend to be highly heterogeneous. So an intervention bundle that works in one setting is not likely to be feasible. And even if it is feasible, not likely to be effective in another setting. The underlying pathologies that we see tend to be very different. In the vaccine work that we've been doing in Kaiser Southern California, focused on HPV, we found a number of sites with 30 and 40% adherence rates. And the standard approach is to develop an implementation bundle and deploy that bundle across those different sites. The problem is that the root causes of the vaccine gaps, the uptake gaps, tend to be very different. And an implementation bundle that includes education and behavior change efforts targeting physicians and nurses, encouraging them to do more, is not likely to be effective in the sites where they're already doing everything that they can. And the reasons for low acceptance are due to factors outside in the community, where we need patient-targeted and public health campaigns and working through social media and peers and so on. So again, the fact that we see similar gaps in implementation does not mean that we need similar bundles of implementation strategies. And again, we know that the implementation bundles, the design and components of complex health interventions tend to vary over time. And that's irrespective of our best efforts to try to achieve fidelity, which again, I would argue is harmful rather than helpful. We need to encourage and guide adaptation and tailoring, not try to suppress it. I also mentioned the problem of multiple mediated causal pathways. So the green boxes here are 4 examples of specific implementation strategies that would be included in a typical implementation bundle. Each of these has causal effects on precursors to guideline adherence, and many of them are mediated. So leadership engagement doesn't have any direct effects on motivation and activation of frontline clinicians. What it does have effects on is the degree of leadership support. It's leaders, in turn, that influence the motivation and activation of clinicians. So when we study complex health interventions, we see lots of opportunities for heterogeneity and variability to enter the causal process. And this is the type of theory-based causal model that we need to be thinking about and using when we design and conduct our research. There's been a lot of work in recent years, much of it led by Carol Lewis, Byron Powell, Brian Weiner, and others. I've had a role in some of it, to focus on the need to study mechanisms of effect. Those of us who used to play the game of mousetrap remember that if you don't line up each of the different mechanisms, something's going to go wrong in this causal pathway. And for us to act as traditional, conventional clinical researchers and measure the input, where the marble drops at the beginning, and then gaze only at the trap on the far right-hand side and ignore everything that happens in between, that's not useful. That kind of research that tells us how often a marble drop leads to successful deployment of the trap doesn't tell anything to us, anything about the mechanisms of effect and how to fix them. So again, we need to embrace adaptation and tailoring, focus on the process as much, if not more, than the impact, and rethink the way that we design and conduct our research. So the key framework here that I mentioned that has been around for a good 20 years. Penelope Hall's first article was published in 2004 when she introduced the distinction between core functions and forms. The rate of uptake and use of that framework in the implementation science field and others was relatively slow for a number of years. I was able to convince the PCORI Methodology Committee to incorporate the framework in its method standards for complex health interventions. We suspect that along with many other publications and efforts, have led to increasing acceptance and use of the framework. But the key idea is to distinguish between the actual activities or components of a bundle, an implementation bundle or another bundle of interventions in a complex health intervention. And here I'm using the word component to describe the form, the activity. We distinguish between the form and the underlying function. One way of thinking about this is to think about talking to a health system leader who is interested in improving care. And rather than giving that leader a manualized intervention, telling the leader what to do, we need to start by telling the leader what we would like the leader to accomplish. What are the underlying purposes or goals? Going back to my the diagram, the causal model, what are the precursors of the desired behavior change? And what kinds of elements need to be included in the bundle that will address those precursors? So here's some examples of core functions versus forms. So a manualized intervention that specifies 20 minutes of walking 3 times a week is not useful. Many patients can't walk, and they don't need to walk. They can run, they can row, they can swim. So again, the manualized intervention should not be so specific and so narrow as to specify scripts and specific activities or forms. It needs to begin by specifying the underlying goal or core principle. Patient education is similar. We should not be specifying in our HPV vaccination improvement programs a brief intervention script that we'd like physicians to use for those patients and parents who have the belief that physicians are agents of the evil pharmaceutical companies and are trying to poison their kids. A physician brief intervention is likely to be counterproductive. So we start by thinking about the underlying gap or need or problem, and that is a patient knowledge gap. We then think about the core function, which is patient education, and we then think about a menu of forms, each of which can operationalize or carry out education, but each of which has different levels of relevance and value for different circumstances. So what do we do with this? We need to rethink implementation science. And again, I'm describing something which is underway and is quite common, but not quite as common as I believe it needs to be. But we need to develop our core function form matrix for implementation science. And we begin with identification of the barriers. There are a number of published articles, as you know, that identify implementation barriers, needs, gaps, and that is in the method that Monica Yolis and I developed, is the first column in a core function form framework. What are the needs? There are knowledge gaps, there are motivation gaps, there are logistical barriers, lack of space, there are fiscal or regulatory barriers. We then list for each of those barriers the core functions. And again, those core functions need to be very general. So it's not a specific educational script that should correspond to or address the knowledge gap. It's patient education or clinician education. For each of those core functions, we then list in the third column in the matrix the corresponding forms, the different ways of accomplishing or carrying out education. Now, we have very good inventories and lists of implementation strategies. The ERIC typology I've mentioned, there are many others, as you know. One of the ways in which we flesh out and fully develop the core function framework is not only starting in column A with the barriers and then developing a list of core functions in column B and a list of forms, but we can also begin by placing implementation strategies in column C as examples of forms, and then sorting them and listing them next to the corresponding core function. Ideally, for each of those core functions that responds to a barrier, we would have a hypothesized mechanism of effect. We need to know how that core function would carry out its effects and address that barrier, overcome that barrier, or address the need. In some cases, individual forms may have slightly different mechanisms of effect, but for the most part, the mechanism is attached to the core function. And it's that resulting core function form matrix that we use to design and deliver, to monitor and refine, and ultimately to evaluate site-tailored implementation bundles. So each implementation bundle for each site will, for the most part, have a very similar, if not identical, list of core functions. There may be some differences because the barriers may differ. Where we're more likely to see considerable heterogeneity in very different bundles is in the collection of forms. So again, going back to my example of patient education is likely to be a core function of every site's implementation bundle. But the specific form that we use, whether it's a nurse educational intervention, whether we provide them with websites or videos or written materials, whether we develop public health social marketing campaigns and encourage key opinion leaders in the community, sports figures, celebrities, to encourage vaccine acceptance, that's all likely to vary. So it's the third column of the forms where we expect to see the greatest tailoring and the greatest need for tailoring. So in general, how do we go about using the core function form framework and approach to study and use complex health interventions? Again, we begin by specifying the core functions and developing menus of forms. The research goal is to not only determine the effectiveness and need for every core function, but also to develop evidence regarding the relationship between different forms and the target. So it would be nice to have a set of algorithms that state, for example, in the vaccine example, assess the beliefs and attitudes of the patients within your clinic. And depending on what you see, determine whether you should select from the menu of forms a physician education, a nurse education, or a social marketing campaign. Those are the algorithms that we need in order to guide site tailoring. And again, the evidence that we as researchers need to develop includes understanding how the interventions achieve their effects, developing and testing the kind of causal model that I illustrated earlier, determining how to improve effectiveness through better tailoring, rather than determining whether they are effective. So what are some of the implications of this sort of approach for implementation science? First of all, as I've indicated, we need to rethink manualized interventions. We do want to have a manual, but that manual should focus not on the specific scripts in a step-by-step approach, but instead the core functions and forms and how to select forms. Personally, I'd prefer avoiding the term manualized intervention, even if we redefine it, because it sort of conveys in the mind of too many researchers a specific approach, and that's the approach that we need to avoid. I would make a similar argument for core components. There are some examples of publications where the term or concept core component is used to refer to core functions, but for the most part, when you see core components, the researchers are describing a list of forms. And as I've argued, forms are rarely, if ever, core. They can almost always be replaced or substituted. I'd also argue that we should avoid using the word adaptation and instead focus on tailoring, which is a trend within the implementation science field. To me, the idea of adaptation sort of conveys the idea that there is a base version of an implementation bundle or another complex health intervention. And what we do is adapt it or modify it to fit other sites. I would argue, in fact, that whatever version we started with is not a core base version. It has no greater relevance or value, rather, than any other version. It just so happens to be the version that seemed to make sense and ideally was effective for the sites that we started with. So we're not adapting away from a base version. We are taking a menu of core functions and forms and selecting different combinations to produce different versions. And to me, the word tailoring seems to convey that different approach. I've said a few different ways, a few times that, thinking about the concept of an effective implementation strategy or an evidence-based implementation strategy, as we typically think about evidence with a capital E, does not make sense. There's no inherent property of effectiveness that attaches to any implementation strategy. They're effective in some settings, under some circumstances, as part of some bundles, but not others. So again, using or conceptualizing evidence and evidence for implementation strategies quite differently. So let me elaborate on just a couple of these and then open up for questions and discussion. So, again, one of the implications of this kind of thinking is that we should never conclude an article with a statement similar to bullet number 1 here. Our implementation bundle was found to be highly effective, because that implies that it's effective in a robust manner. But in fact, when we see an implementation bundle that did produce positive effects, all that means is it was positive in enough sites that the average effect size was positive. There are many sites in almost every study, if not every study, that showed harm. To me, that doesn't mean that it's highly effective. If it harms even one site, we haven't done our job. But again, the implementation bundle, if it was found to produce positive effects, did so in the group of settings that happened to be studied during the particular time period of interest, with the support of the research team that happened to be available and on the ground, and the grant resources that provided, and because of the unique combination of leaders and staff and patients and other stakeholders. That one positive finding is one highly idiosyncratic finding, and there's not much by way of generalizable evidence that we can take from that study that relates to that implementation bundle elsewhere. Let me talk about a few other some miscellaneous implications of all of this. One of them is the concept of the tyranny of averages, and the observation that, again, if we're dealing with vaccines, if on average the vaccine is effective and we don't know how to tailor it, well, we can't tailor vaccines. We're beginning to tailor other clinical interventions, again, through precision medicine. But if we can't tailor it, all we can do is say yes or no. But if we find an intervention or an implementation bundle or a patient safety program or a checklist, to use one example that suffers from this problem, for which the average effect was positive, but that average effect was due to a very skewed distribution. And we see that, for example, in a dozen sites, 3 of them did very well, and 9 of them showed no change or even harm. If the effect among those 3 is so great that the average was positive, we would erroneously conclude that that's an effective intervention. As a health system leader, I would not be very interested in an intervention where only 3 out of 12 sites showed a positive effect. So we need to think about how we present the results of our studies and avoid the tyranny of averages. Sort of related to that theme is the idea that as a health system leader, again, I don't really care much how this intervention worked in other sites. What I care about is how it's likely to work for me. So knowing the average effect size is far less valuable to me as a health system leader than understanding who did well and who did not, why, when, where, for whom. But more importantly, how can we help that health system leader to tailor and adapt the intervention to his or her circumstances? So again, the typical results of research and the kinds of findings that we think we should be producing researchers aren't of as much value in our field as other forms of output. And I would capture that idea by saying that we don't need to produce evidence as we traditionally understand it with a capital E, but instead our role should be to produce insights and guidance. We are not trying to support an FDA decision. We're not trying to determine if it's effective or does it work. We are trying to produce evidence regarding how it works, why, where, when, and for whom. And again, how can we enhance its effectiveness? And that directs our attention to the process rather than the overall impact. So again, sort of hidden within my talk was a roadmap in an outline for the effort that I'm involved in with colleagues that is converting the existing implementation strategy typologies to the core function form framework. We're still a little bit too early for me to be interested in presenting it, but anyone who would like to see an early draft, please get in touch with me. But the hope is that that approach provides a much better way for us to conduct our research, to design and deploy effective implementation bundles, and to provide guidance to decision makers that will address the glass house problem and will ensure that what we do as researchers is much more useful for policy and practice audiences than many of our colleagues who are criticizing us in this area feel that we are right now. So not quite 20 minutes left, but close. I'm open for questions, complaints, alternative viewpoints. So,
Yeah.
Thank you.
Thank you, Brian. It really provocative and also, as you started off, a lot of insights from, and I really appreciate the focus on practice and what really works in practice. And there's some fantastic questions here that we should just dive into. And so maybe the first one is a little more straightforward, but a good way to start off with the other question, which is, could you please explain a bit more about the difference between adaptation and tailoring in the way you were talking about it?
Yeah, so like core components and some of the other terms, they're all used in very different ways. And it's not necessarily that we shouldn't ever use the term manualized interventions or adaptation or core components, but the way that they're used often, I think is misleading. The specific complaint that I have, an observation about adaptation, is that it's often used in a way that says, let's start with a base version of an intervention bundle. And that's sort of the core effective version. But we then need to tweak it and refine it in certain ways to fit other circumstances. it places a higher level of respect or weight on that starting version. And in my mind, any starting version of an intervention in any study is somewhat arbitrary. Again, it was developed by and for a specific site, so we shouldn't give any more weight to that version. Adaptation, the way that I understand it, does imply that we're adapting away from a base version, whereas tailoring could be used to imply that we're starting with a list of core functions and developing a tailored version for every single site. So it's probably an argument that most of our colleagues won't accept, but I think the underlying point that there's no greater value or strength or legitimacy of any given version. To me, an implementation bundle or any complex health intervention is a mix of selections from multiple forms, menus of forms. And just like there's no meal from a menu that is better than any other, we can choose any one of the proteins or any one of the starches or any one of the vegetables and have a meal that's equally good. We shouldn't view the meat and potatoes and lettuce or salad as the base version against which everything else should be adapted or compared.
Yeah. But Maria, if you don't mind me putting you on the spot, I think this is just a great topic to also talk from the adaptation side of things. You do a lot of great work in that. The I am adapt framework is something that is such a great feature of the work of our institute. Can you also kind of reflect on this as we go?
Yeah, thank you. Thank you, Vigil, and thanks, Brian, for a fantastic presentation. I agree 100% that when you're looking at an intervention or an implementation strategy, that thinking that the forms are really sort of the thing that has to be maintained and that's the main starting point is often leading us down a path that probably is not right because of all the reasons you mentioned. On the other hand, I think that, and you also mentioned that you don't like the term core elements, and the reason that you don't like it is because a lot of times people are talking about the forms, like how something is operationalized as the core element. And I would say that if you think about the core elements as the functions, right, which we often do when we're developing strategies using implementation mapping or trying to adapt strategies using I am adapt, we really focus on those core functions. Now, the core functions could also be different, right? You could also find that those things that influence implementation in a particular setting are different than the things that influence implementation in another setting. And so what you think would be a core element actually isn't anymore. But I guess my comment is I agree with you, and we have to be careful about how we use adaptation and core elements. My question and concern about the term tailoring, and this actually was raised as a concern of mine just very recently, and when I was at the CIRC conference, the Society for Implementation Research Collaboration, where there was a systematic review that was being done about the extent to which tailoring had happened in many different settings. And they defined tailoring as just had they assessed determinants of implementation before they chose or developed a strategy. And I think that that's a very broad term for tailoring. And so I'm just a little concerned about that term as well, not to open a whole nother can of worms.
No, I
Yeah,
think
so no,
this is
go ahead.
great, and it feels like a little bit like our presidential debate. So Dr. Mittman, I'll give you 10 seconds to respond, or 15. No, I'm joking. Go ahead.
No, I will respond quickly because I would like to leave time for others. So I completely agree about the issue of using the word. So the term that I see used most often is core components in manualized interventions. Those are not inherently bad. The problem is they're used in different ways. And when we do understand core components to mean core functions, that's what we need. The problem is too many times a list of core components is a list of forms. And again, it's not true that the physician brief intervention is a core component. without which the intervention effectiveness would fall apart. It's easily substitutable. So anyway, that's my beef, my issue with core components, the way that it's used, not that it's inherently bad. Similarly with manualized interventions, if we understand the concept manualized intervention to mean a highly detailed, ultimately idiosyncratic set of scripts and protocols, that's harmful. If we instead reconceptualize the manual to start with and to prioritize problem and need assessment and core functions, and then the manual includes menus of forms and guidance on how you select from that menu, that's the kind of manual that we need. So again, it's the way that the term is used and what it sort of triggers in our mind. The issue of tailoring is problematic because it makes sense, I think, to all of us that we should tailor to sites. But when we try to collect evidence as to whether site tailoring is effective or not, it will be effective only if the tailoring decisions were appropriate. And so if we spend a lot of time trying to tailor and we end up choosing the wrong items from the menus of forms, we're back where we started from and having a mismatch. So, it's a dilemma.
Yeah. No, great discussion. Let me pick another question here, another topic actually. So given that the message you highlighted, the importance of tailoring implementation strategies, I can see that the generalization and replicability of the evidence may relate more to functions rather than forms. Could you discuss how best to address or approach the generalizability and replicability of implementation strategy research? I think it's a fantastic question.
I think it's important. And it is, again, one of the changes in the way that we sometimes do research. And, this is being done to a great extent. But, it's, to me, the simple example is, physical activity. We shouldn't be designing and evaluating an intervention that uses one specific form of physical activity. The goal of research, the empirical evidence that we need, is the effectiveness of physical activity on the health behavior outcome of interest. And if we can set up the study properly and tell each of the sites to be sure to prescribe a form of physical activity that's likely to be most suitable for each individual patient, and we measure the fidelity to the core function, not to the form, then we are developing the evidence base that we need. So, it's not a major change in the way that we go about designing and studying, our interventions, in the same way that oftentimes with a vaccine study, we don't care if it was given in the left arm or the right arm. We don't care most of the time whether drugs are taken in the morning or afternoon, with or without food. Sometimes we do. So we need to think about those as equivalent to a menu of forms, where the differences are more related to a match with the individual target and the form that will be most effective in carrying out the core function. But the evidence relates first and foremost to the core function and secondarily to the form.
Yeah, no, that's great. So it's another question that's now focused on sustainability. I'm jumping around a little bit to connect the dots here. And this person says, I apologize that it's a basic question, and I actually don't think it is. Where does sustainability come in the implementation science process? Is in the field of implementation science more focused in the frontier part of introducing an evidence-based intervention to the field, or is sustainability also included in the field of study? I think so important. Yeah.
Well, so one answer is for us to understand why it is that many implementation studies are effective. And one of the main reasons is that we've selected a set of sites that we understand. We have provided and used grant resources to support additional staff, where we supervise the staff. We're often on-site generating Hawthorne effects by interviewing or surveying the physicians, so they know they're under the microscope and tend to adhere. And that's basically an efficacy-oriented implementation study. We need to conduct effectiveness-oriented studies that have an eye towards sustainment and scalability. And again, I would argue that the core function framework provides us a method certainly for scaling, so that we can develop evidence regarding a robust sort of fundamental foundational package of intervention activities with built-in tailoring in that package. But I completely agree that, the efficacy-oriented studies are rarely all that useful, and that we need to be thinking in the very beginning about effectiveness conditions and the kinds of conditions that are likely to result in sustained use of the intervention, rather than having the artificial supports like the study team and the grant resources and everything else withdrawn at the end of the study, in which case things tend to fall apart.
Yeah. Thank you. So continuing on still on the form function thing, there's another really interesting question about ERIC. So doesn't the approach that was used in generating the ERIC typology, which was multi-stakeholder, which was collaborative, suggest that the identified strategies as described in that typology are themselves functions in the sense of being transferable?
That kind of thinking, I believe, was implicit and is implicit in the work that all of us do. We don't deploy education because we read somewhere that education is important. We have the implicit understanding that education is effective in addressing the knowledge gap. And Maria commented on this, and intervention mapping, implementation mapping, incorporates all of those ideas. So, part of what I'm arguing in the reconfiguration of ERIC into a core function form sort of framework is not a major shift. It's making something explicit that was implicit, and it's developing an inventory and classification that I think, Maria, you and colleagues who follow your approach, I believe, should find more useful and more compatible with what you do.
Yeah, I'll just add
yeah.
that. Yeah, just a couple comments. So, I mean, the tremendous work that has advanced the field a lot with the ERIC strategies was an attempt to characterize what was already happening, right, in the field. And yes, multiple stakeholders, and there's been a lot of progress in trying to understand and more recently map the mechanisms of these implementation strategies. But the ERIC list is not a list of, first of all, effective strategies, right? It's just the list of what was used with really not that much attention to did it work or not and in what context. And there's also a lot of variability from strategy to strategy in terms of the specificity. So you might look at one strategy and say, oh yeah, that kind of looks like a function, right? And then you look at another one and it really is a form or even a very broad category. And so I think that because of the nature of what was already out there, which is essentially where the ERIC compilation came from, it's that question that you ask is sort of, it depends on what specific strategy that you're looking at. But I think that the work that Brian mentioned that they're doing, other groups are looking at, what are the mechanisms of these strategies? I think that's going to advance the field a lot and make it easier to understand, what parts are core.
And it is evolutionary rather than revolutionary. And just one other quick comment, and that is, placing everything in ERIC and the other typologies into the framework, where I agree that some items will end up in column B, core functions, others in column C, and then, listing all the barriers, there probably are gaps. And so one of the benefits of using this matrix approach is that we will identify gaps, and we will identify problems for which the current list of core functions and forms that have been used, as Maria just said, is a little bit weak and thin, and we could envision others that can then be used in the future. So it's a way of simply documenting, and as any typology or any framework, you take a lot of items. Our colleagues in biology do this all the time with various classification schemes. That's really the evolutionary nature of this activity.
So I'll take one last in the minute we have, which is on quality improvement and implementation science. While we understand the importance of tailoring, would you say that virtually every implementation context requires QI work to produce their tailored strategies? And it's important. It's kind of the orientation I take to a lot of the work that I do in implementation science. And what is quality improvement? Where does it fit in the field of implementation science? And especially the clinical world sees QI, they know the importance of it. It's familiar to them, so on and so forth. So if you can kind of connect the dots there, I think that would be great.
Yeah, so a lot of the underlying thinking and sort of the philosophy or the assumptions about the nature of the world and the complexity and the need for us to try something and then quickly monitor it and try something different is one of the hallmarks of the improvement science approach that we need to do a better job of incorporating. But you could also argue that clinicians do this. You diagnose a set of clinical symptoms, prescribe a medication, and then in the case of antidepressives, in the case of antihypertensives, you then monitor and you titrate and refine. So it's an approach that's used, in other domains, but it is one of the, again, hallmarks of the QI approach, where we assume that we can't sit back in our office and use theory and empirical research to design our evidence-based implementation bundle and manualize it and deploy it and then come back 6 months later to see if it worked. We have to be on the ground monitoring and refining with the guidance of something like a core function form framework.
Yeah, no, thank you so much. I mean, if I can put a small plug here, actually in a couple of weeks, I'm speaking at Cincinnati Children's about quality improvement and implementation science myself. So we'll be putting that talk up on our institute website for anyone who wants to attend as well. But fantastic. We can keep talking. We're 1 minute over, but thank you everyone for attending. Brian, thank you very much for a very insightful and provocative presentation and discussion. Maria, thanks for jumping in as a panelist on unplanned, but this was fantastic. Really loved it.
Okay, my thanks as well.